Good afternoon, everybody. I'm Ron Ackerman, Director of the Northwestern University's Institute for Public Health and Medicine, and I want to welcome you all to today's webinar. Before we begin, I want to remind you that we encourage audience participation in these presentations. To do this in the webinar format, simply use the Q&A button at the bottom of your Zoom screen. Our speakers will use the Q&A to field questions during or at the end of the presentation today. Please avoid using the chat function as we don't monitor that for questions during the webinar. I'm delighted to introduce our presenters for today, our very own Doctors Tara Lagu and Carol Haywood, who will present on the topic of identifying and addressing inequities in healthcare for people with disabilities. Dr. Lagu is professor of hospital medicine at Northwestern's Feinberg School of Medicine and director of IFAM's Center for Health Services and Outcomes Research. Dr. Haywood is research assistant professor of medical social sciences at Northwestern's Feinberg School of Medicine and a member of the Center for Health Services and Outcomes Research. In today's talk, Drs. Lagu and Haywood will discuss under-recognized health disparities experienced by people with disabilities in the United States and what is known about barriers to accessing healthcare. They will highlight their research on physician attitudes relating to care for people with disabilities, including findings from focus groups where physicians describe barriers in primary and specialty healthcare and resulting discriminatory practices. They will also share results from a nationwide survey of physicians, which revealed widespread ableism and gaps in knowledge to support safe and appropriate care for people with disabilities, as well as findings from recent focus groups with medical students and faculty leaders from across the country who are engaged in advancing disability-related medical education. The discussion today will end with a summary of best practice recommendations to advance healthcare equity through accommodations in clinical care and changes to medical education. So without further delay, I'm delighted to hand the control of the webinar today over to Drs. Lagu and Haywood.
Thank you, Dr. Ackerman. It is such an honor to be here speaking with this community about this particular topic alongside Dr. Lagu. Before I start, I want to just provide a brief visual description of myself for anyone who is using alternative access to today's presentation. I identify as a white woman. I have long red hair that's hanging past my shoulders and currently wearing a light pink blazer and some pink earrings for the day. Go ahead to next slide. So Dr. Lagu and I have no disclosures to report, but we do really want to take a moment to acknowledge many people who are collaborators and great supporters of this work who continue to propel it forward here at Northwestern and beyond. Next slide. More than 61 million Americans identify as having impairment relating to physical function, intellectual function, visual function, communication, or mental health that contributes to disability. This population is in no way a monolith. It's incredibly diverse and highly intersectional. There is not another group across society who does not include people with disabilities. And my role at the beginning of our talk today is to really spend some time setting the context for our research and to really set the stage for having a common understanding of who we are talking about when we talk about people with disabilities and why it's important to really have a shared understanding of who this population is and why that's important. Next slide, please. People with disabilities or experiences of disability are across a full spectrum. There are invisible disabilities, oftentimes many mental health conditions. There are also visible disabilities, such as someone who might use a wheelchair to move from one place to another. Disabilities are oftentimes co-occurring, and they can be stable or fluctuating or progressive at any particular moment in time. We also think about disabilities that occur acutely. So we might have a really brief experience of disability or a chronic experience of disability. And importantly, disability can impact anyone at any time. And in some respects, we can really only all be so fortunate to reach an age in which we are almost sure to be impacted by disability. Next slide. And just as all of the ways that we identify ourselves, the language that we use is really powerful and really important to consider. And so I want to take a moment to acknowledge the different language that we can use when we're talking about people with disabilities. There is a person-first approach to speaking about disability, in which we really recognize the person or the human in front of the disability. So we might say, I am a person with tetraplegia, or I am a person with autism. In direct contrast to that, there is an identity-first language which really reclaims the power of disability. And in this case, you might say, I am a tetraplegic, or I am an autistic person. These preferences vary and are highly individual, just like all the ways we identify ourselves. And so really we should treat these much like we treat other forms of identity, like gender pronouns. We can have a conversation about what preferences are and how people prefer to identify themselves. But broadly speaking, we default to person-first language to really acknowledge the humanity in all of us. Next slide. I want to take a moment to talk about the different models of disability, and I'm just going to really feature 3 today that are most common, because the models of disability really inform the work that we do, and they inform, they also hold a lot of power, much like the language, because they are a reflection of our orientation of the origins of disability. So the medical model of disability is the most enduring model. And this is oftentimes what we think of, particularly in these spaces like a school of medicine where we work, and in healthcare practice, the medical model of disability is pervasive. It locates disability within the individual. So the individual has the disability. And in many cases, disability is seen as a problem or pathology or a defect, which is to be diagnosed and cured, and in some cases even thought to be needed to be eliminated. Next slide, please. The social model of disability really places the disablement in society or in the environment. And so it's not the person themselves that has the disability, it is the environment within which a person is functioning, which causes disability. This is the social model of disability. And I think that this image from Jamie Shields really lays this out nicely. When I can't access your website, you disable me. When I can't access your building, you disable me. It's not the fact that I'm using a wheelchair that causes my disability. It's my inability to actually get across the threshold of your building if it only has stairs or doesn't have an alternative entrance. The wheelchair in and of itself does not have to be disabling. When your recruitment process isn't accessible, you disable me. When your company culture isn't accessible, you disable me. And when your content isn't accessible, you disable me. Next slide. The World Health Organization talks about disability as part of being human, and again, describes that almost everyone will temporarily or permanently experience disability at some point in their life. The World Health Organization brings together the medical model and the social models of disability and adds some additional nuance thinking about how disability is experienced in the world, saying that disability results from the interaction between individuals with a health condition and their personal and environmental factors, including negative attitudes, inaccessible transportation and public buildings, and limited social support. Next slide. So the last model I want to share today is the International Classification of Functioning Disability and Health, which is more commonly known as the ICF. And this is the World Health Organization framework for measuring health and disability. And as I mentioned, it integrates these medical and social models of disability into a broader biopsychosocial model. And if you look on the right hand of the screen, you'll see at the top is a health condition which interacts in multiple directions with a variety of factors, including contextual factors like what's happening in physical and social environments, personal factors, and that comes together to influence body functions and structures, activity demands, and levels of participation within an activity. And those different constructs are how we can think about and start to measure disability within a particular context. Next slide. And yet we're still thinking about how do we define disability and what are some of the important common language around disability. Next slide. So the Americans with Disabilities Act defines a person with a disability as a person who has a physical or mental impairment that substantially limits one or more major life activities. This includes people who have a record of such impairment, even if they do not currently have a disability. It also includes individuals who do not have a disability but are regarded as having a disability. Next slide. The Social Security Administration says that in order to qualify as a person with a disability, you must not be able to engage in any substantial gainful activity, think employment, because of a medically determinable physical or mental impairment that is either expected to result in death or has lasted or is expected to last for a continuous period of at least 12 months. Next slide, please. So these two definitions, I put them together because they stand in high contrast to one another. And the origins of these definitions is really important to consider because the ADA, the Americans with Disabilities Act, is arguably the most important piece of civil rights legislation put forward for people with disabilities. And the definition here is intentionally broad in order to be inclusive. In contrast, the Social Security Administration uses their definition of disability to determine eligibility for services. And so their definition is narrow in order to limit the number of eligible beneficiaries. Next slide, please. So in 2000, the Department of Health and Human Services published their issue, Healthy People 2010. And this was the first time that people with disabilities were listed as a group that might experience disparities in care. And they attributed these disparities partially to erroneous assumptions about daily lives, values, and expectations of people with disabilities. Next slide, please. Specifically, they said common misconceptions about people with disabilities contribute to troubling disparities in the services they receive, especially, quote, an underemphasis on health promotion and disease prevention activities. Next slide. So one of the charges within Healthy People 2010 was to say, if we're going to move the needle on health for people with disabilities, we have to first be able to identify them. And specifically, the charge or the objective within Healthy People 2010 was to develop standard questions to identify people with disabilities within data sets. Unfortunately, that was not achieved by the end of Healthy People 2010, and so it was rolled into Healthy People 2020. Next slide. But with the Affordable Care Act and a mandate for documenting disability, the Department of Health and Human Services developed a data standard which rolled out in 2011 and has remained consistent. So these 6 questions that you see here are the data standard for disability status, which are now widely used, including by the US Census. There are arguably some gaps in these questions or some flaws in these questions as we might start to pick them apart, but we have to accept that they are the most broadly used and they inform much of how we can measure and understand disability across some of the broader data sets that we use now in research. Next slide, please. So ultimately, these varying definitions of disability combined with the heterogeneity of the population of people with disabilities and the intersectionality of this population, especially when we think about compounding impacts of different identities, leads to gaps in data and monitoring, which ultimately make it difficult to truly measure some of the inequities that people with disabilities experience in everyday life, and specifically in healthcare. They also make it difficult to merge data or compare data across studies, and there's difficulty in identifying people with disabilities in various systems and trials. Next slide, please. Still, there is compelling and persistent evidence of inequities in health and healthcare for people with disabilities. Next slide. So the CDC uses or puts forward a disability and health data system, which pulls data from the BRFSS using those 6 questions that I mentioned previously. And just to give you a quick snapshot, Dr. Lagu is going to get much more into the details of some of the inequities that are documented, but 1 in 4 adults with disabilities do not have a usual healthcare provider. 1 in 5 have an unmet healthcare need because of cost identified in the past year, and 1 in 4 did not have a routine checkup within the past year. And so there is compelling reason to recognize people with disabilities as a disparity population. There's, again, evidence of higher rates of chronic disease, lower rates of use of primary and preventive care, People with disabilities fare poorly on virtually all measures of social determinants. They often experience housing insecurity. As I mentioned with Social Security Administration, they are essentially forced to live in poverty in order to remain eligible for many benefits, and therefore meet these criteria for being a disparity population, although that recognition is not consistent. So the CDC, HHS, and AHRQ recognize people with disabilities as a disparity population, but importantly, NIH does not, and this continues to have pretty critical consequences in research and moving this work forward. Next slide, please. There's a long history of legislation to protect the rights of people with disabilities, dating back more than 50 years. One of the most important pieces of legislation was Section 504 of the Rehabilitation Act, passed in 1973, which really prohibits discrimination against people with disabilities in federally funded programs and services. And then maybe most importantly, the Americans with Disabilities Act, which first passed in 1990. There was an ADA Amendments Act to strengthen the laws in 2008, but ultimately the ADA required provision of healthcare services with reasonable accommodations. And the Affordable Care Act strengthened these protections. But what we know is that this legislation has not yet, put a little bit of hope here maybe, not yet led to meaningful change. Next slide. And there are really critical consequences to these barriers to healthcare. People with disabilities report that as a result of barriers to accessing care, they may delay or skip care. They may drop healthcare providers. They report feeling a loss of agency or trust in healthcare systems. They report feeling like a burden to the system, and they report feeling dehumanized. Next slide. So this model may look a little bit familiar because it really builds on the ICF, but it's a model to show how healthcare disparities can uniquely occur for people with disabilities. And what you'll see is somewhat familiar in the ICF, that it's an interaction, a multi-direction interaction between one's health status, their environment and personal factors, and what's required of an activity, levels of participation, and their body functions and structures that results in an experience of disability. What's added here in this model of healthcare disparities and disability is importantly access to healthcare, affordability, availability, accessibility, acceptability, and accommodation. Next slide, please. And so before I pass to Dr. Lagu, what I want to really emphasize here is that we know that ableism is alive and well, and that is at the backdrop to the work that we do and what continues to motivate us in this research and other advocacy efforts. So I want to define ableism using this working definition from Talila Lewis. Ableism is a system of assigning value to people's bodies and minds based on societally constructed ideas of normalcy, productivity, desirability, intelligence, excellence, and fitness. These constructed ideas are deeply rooted in eugenics, anti-Blackness, misogyny, colonialism, imperialism, and capitalism. And this systemic oppression leads to people and society determining people's value based on their culture, age, language, appearance, religion, birth or living place, their health or wellness, and or their ability to satisfactorily produce, excel, and behave. And importantly, you don't necessarily have to be disabled to experience ableism. So it's a huge issue. And with that, I will pass to Dr. Lagu.
Thanks, Carol. I love that definition, and I like to say all those isms in one talk together. So thank you so much for bringing that to our attention. I often get asked when I present this work how I started working in this area. And I think I have to tell the story, and I apologize for those of you who've heard this a million times. But I was seeing patients in the hospital, and I was discharging a patient who used a wheelchair, and she had very attentive daughters. And she needed an appointment with the urologist. And I said to the daughters, you take such great care of your mom, and yet every time she's in the hospital, I see that it's been documented that she needs this appointment, and you haven't taken her for this appointment yet. And her daughter said, well, we'd love to make an appointment with a urologist, but we can't find one within 100 miles of our house who will see a patient who uses a wheelchair. And I said, no, there's a law and I'm a doctor, so I'm gonna make some calls. And yet when I went to call physicians within 100 miles of her house, I couldn't find one who would see a patient who used a wheelchair unless she was brought by EMS and transferred by paramedics to an exam table. And of course, when I said that to the daughters, they said, oh, we know that would cost us more than $1,000 out of pocket. And so I discharged the patient without having an appointment for her. And as they sort of went out the door, the daughter said to me, this is discrimination or something. And I said, you're right. And what we have to do is study it. And so now, more than 10 years ago, working on an unfunded study with medical students and residents who were volunteers during their summers or their months off, we conducted a telephone survey where a physician or a student would call doctors around the country and ask them if they would make an appointment for a fictional patient based on my real patient who used a wheelchair. We used an iterative approach to design the sort of clinical scenarios. And that was that this patient, very much like the patient I discharged, was hemiparetic due to a stroke, unable to bear weight, could not transfer herself. And we used clinical scenarios specific to the specialty. And we asked if the practices would make an appointment for the patient. And if they could the patient both get into the building and be transferred to an exam table for an exam? And if they couldn't, we usually would talk at some point to the practice manager and say, what was the barrier? Was it the patient couldn't get into the building, or was it that you could not transfer the patient to an exam table? We called more than 250 practices across the country and found that 22% would refuse to make an appointment for a patient who used a wheelchair. Only 9 of these were in inaccessible buildings. More than 40, most of the rest could not transfer the patient to an exam table. And of the remaining 200 accessible practices, more than half plan to transfer the patient in a way that was considered unsafe by disability experts. That is, they would transfer the patient from a wheelchair to a high table, they would have untrained staff, and some of the cases were so unbelievable that we couldn't put them in the paper, but I'm still talking about them because I would say, oh, can you transfer the patient? And they'd say, yes, we have a parking attendant. They come in, they transfer the patient, or some other kind of unbelievable thing that you would never want to happen to you or a family member. Fewer than 10% of practices had height adjustable tables or a lift or other equipment that is considered safe for transferring patients. And this was consistent with prior work that had been conducted in the state of California that documented about 10% of practices there with similar equipment. And so overall, we identified that only 1/5 of the sample was totally inaccessible, but many were unsafe, few were ideal. I always highlight gynecology, but not because anything is bad about gynecologists, just that it's a subspecialty where you absolutely have to transfer the patient to an exam table. So it had both the highest rate of inaccessible practices, but also the highest prevalence of height adjustable tables. So we published this paper, and I was thinking, this is a big paper, it will change practice. And yet, when we started looking into it further, we realized that this wasn't really the case. And what I'll say is that we subsequently published sort of recommendations in the New England Journal of Medicine for how physicians should accommodate patients, and I'll talk about some of those later. And then subsequent to that, we conducted another study where we examined perceived quality of care for patients with disabilities at clinics with and without accessible equipment. And what we found in that study was that the perceived quality of care was no different if there was the presence of height adjustable tables or lifts, and the likelihood of being examined was also not different. And so at that point, we stepped back, and I had now spent 3 to 5 years talking about how what we really needed was height adjustable equipment, and we needed tables, and we needed trained staff. And at that point, with my collaborator, Lisa Azzoni at Mass General, we realized, oh gosh, this is really about something more than just equipment. There's something going on with physician attitudes. And so at that point, we wrote a grant to NICHD where we said, let's just really hone in on physician attitudes towards people with disabilities. We'll start by conducting anonymous focus groups and talking to physicians about their experience of caring for people with disabilities. We'll then conduct a national survey of physicians to understand their attitudes towards people with disabilities in a more generalizable way. And finally, we'll conclude with interviews with advocates and medical students and faculty. And so I'll talk about some of the findings from the survey in a moment, but the first aim, the focus groups, had some really alarming findings, which have been highlighted in the press quite a bit. I'm going to get into those a little bit more. So what we did was that we conducted focus groups with 22 physicians who were chosen for their diverse location, their difference in specialties, half men, half women, and we aimed for some that were practicing in rural settings and some that were practicing in non-rural settings. And so across 3 focus groups, we designed an interview guide based on barriers that we had identified in previous work: physical barriers, communication barriers, knowledge and experience and skills about caring for people with disability, structural and system problems, knowledge of the ADA, and attitudes that physicians expressed about caring for people with disability. We then asked about specific disability groups: people with mobility problems, hearing problems, vision problems, communication, mental health, and intellectual disabilities. And from this, we had a very surprising finding, which is that actually some physicians described specific strategies that they used to discharge people with disabilities from their practice. So first, we had conducted these focus groups, and they were anonymous, and it was in a Zoom setting. We only knew first names, we knew where they were located, but we didn't have any other additional information about the physicians. That's notable. Second, we started out by asking about things we knew about. We asked about physical barriers. We asked, are your patients weighed? Are your patients with mobility impairments weighed when they come to your office? And so some of the sort of responses we got in these physical and communication barrier categories were not that surprising. Our medical assistants just write wheelchair, and the weights don't get checked until someone makes a big deal about it. And this is consistent with prior work that Dr. Azzoni had done, where we had samples of patients who had been pregnant and during their entire pregnancy were not weighed once because they were using a wheelchair. There were communication barriers. Many of my patients have hearing aids that aren't working. It's better to just use a paper and pen. And of course, this is not the recommended way to communicate with people with communication problems. And in fact, many reported not asking their patients how they prefer to be communicated with. There was a real lack of knowledge on the part of physicians, and a theme that emerged was that physicians said, I don't even know how to care for people with disabilities. I'm not qualified. There are clear structure and system problems, and some of this had to do with sort of the time that physicians perceived that providing accommodations take and how that works in to their otherwise already busy days. Seeing patients at a 15-minute clip is absolutely ridiculous. To see a patient with a disability in those timeframes is unreasonable and unacceptable. There was also a lot of statements about total lack of knowledge of the ADA, and in some cases, really feelings of negative attitudes about the ADA on the part of physicians in these groups. I truthfully think the ADA makes the disabled person more of a target and doesn't help them, but hurts them, because a lot of us, me personally, are afraid to treat them. We just don't want to deal with them. And this was a lot around the description of being afraid of lawsuits related to the ADA. And then finally, and I always have to sort of describe this a little more, these focus groups were conducted after hours, because that's when physicians tend to be available, and had almost a chummy feel towards them by the end. And in some cases, it went from the moderator, who is actually Dr. Azzoni, who is a person who uses a wheelchair, asking questions, to a conversation between members of the focus groups. And that's sort of what happened in these 2 focus groups where these statements about denying care came out. It was really a conversation between people in the focus group who had spent more than 2 hours talking about their experiences with working with people with disabilities. And then at the end, really devolving into a conversation about their frustration and then their eventual decisions to discharge people with disabilities from their practices. I've thought a lot about it because in a sense, we're kind of in a powerless position to deny care. So my solution is to say, I no longer take new patients. Another person says, no, 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 you have to say you can't take their insurance. And then another person says, no, no, no. I say, I think you need a lot more care, and I am not the doctor for you. So I'll say a couple things about these focus groups that I've said somewhat, to the public, but I think is worth saying here again, which is that we had research staff who had to watch these, many, many times. And at one point in the course of doing this analysis, at least 2 members of my staff came in and were like crying and feeling extremely frustrated and marginalized. because of the statements that physicians made in these focus groups. So I think it was, the quotes are very powerful, but I think watching the focus groups was in some ways even more painful. We took some of these responses and quotes to Jamelia Morgan, who runs the Center for Race and Disability Justice at the law school at Northwestern. I encourage you to look into that because she's doing really great work there. And we talked to her about really what was happening here and how does this relate to the ADA? The answer is that, of course, physicians have the right to exercise discretion in who their patients are. Physicians do it all the time, right? We make choices not to take a certain insurance. But what physicians can't do is discriminate against an entire group of people. And that was what was seemed to be happening here. The physicians in these focus groups were saying, I discriminate against an entire group of people. The problem is that the ADA is enforced through lawsuits. And so while some of the excuses that the physicians in these studies gave were possibly, or maybe even probably, discrimination, identifying intent is difficult. And the patients that they're talking to probably are going to have a really hard time making a case that their rights were violated. And the ADA is particularly difficult, I think, in this sense. The other thing is that, and I've written about this in op-eds and other places, I think that, yes, this is obviously discrimination in some cases against people with disabilities, but it also is a reflection of the way that the healthcare system is failing us all. Physicians in this study described being overwhelmed, overworked, that they couldn't do the jobs they had and the time they had, that they couldn't provide accommodations without losing money on every patient, and many of them were in private practice. And so it demonstrates the bigger problems with the way our healthcare system works for all of us. And the RVU system and others were part of the reason that physicians had such a hard time in this case. But they also suggest that many of the disparities that we see for patients with disabilities, the ones that Dr. Haywood talked about, may be in part perpetuated by physician attitudes and bias. We then did a series of surveys of more than 715 physicians practicing across the United States. And this confirmed some of the work that we had identified from the focus group. Only 57% of physicians in the survey agreed they strongly welcomed people with disability into their practice, which suggests that more than 40% of physicians nationally don't welcome people with disabilities to their practice. Only 40% were confident in their ability to provide the same quality of care to patients with and without disabilities. And more than a third reported that they knew nothing or very little about their legal responsibilities under the Americans with Disabilities Act. So after my first paper, we actually wrote a New England Journal article where we talked about how to improve care for patients with disabilities. And this is a prime example of, if you think you could change the world by writing an article in the New England Journal, actually probably isn't going to work like that. Because we defined in that paper that there were domains of access that we felt that needed to be followed in healthcare settings to better accommodate people with disabilities. So that is physical access, that there needs to be a room with room for a wheelchair, then transfer to an exam table, which is ideally height adjustable, space for that transfer, an accessible route in and out of the room, a bathroom. Additionally, and this is something that we're working on here at Northwestern, and we are very lucky to have buy-in from Cindy Barnard and others in healthcare quality on this, which is that part, and this is fake, this picture, it doesn't reflect what scheduling systems look like, but what we're trying to convey is that knowing that a person is coming, that a person with a disability is coming and needs accommodations, booking a room that has a height adjustable table or a sign language interpreter in advance really helps to alleviate some of the problems that physicians in our studies have described. So that by providing accessibility through both the scheduling system and the electronic health record, and that is having areas where we can identify that a person with disability exists and is in our health record and we know about the accommodations they need, can really help to alleviate some of the barriers that we've seen. And when people say they don't believe this is possible, I will say, I have not seen in my time a person with a latex allergy be handled with latex gloves, as an example. I think we do a good job in some areas of alerting people using administrative methods about problems that our patients have. We know about penicillin allergies and latex allergies. We know about needs that our patients have for other things. We're getting better, we're not great, we're getting better at knowing people's pronouns. So if we can do that, we can do this. We can alert the system in advance and accommodate the patient without adding a lot of work for doctors. Finally, I think communication access continues to be key, and we're actually just about to start a randomized trial here to improve communication access for people with disabilities. And some of this is, providing large print forms and other accommodations for people who are deaf and sign language interpreters, which I think we tend to do pretty well in large systems like this. But I think the other thing is that knowing the patient is coming, having that available in a timely way, having the administrative piece is really key. So although I wrote about this in the New England Journal, it really is only the beginning, and we have a lot of work to do. And what I've said again and again is that there's no healthcare system in the country that's really doing this right. And so we have the opportunity to lead in this area if we choose to. I think we are. So one of my kind of reflections again is that the ADA is a great law, but it really is limited in our ability to enforce it. It's difficult to enforce when you just think about every clinical site, even in a single healthcare system. Additionally, we have the problem that unlike, say, for example, race or insurance, there's information about disability that we don't collect at the time of registration. And so the result is, we do have some ideas about the disparities that people with disabilities face, but we're actually quite limited in knowing that because we don't collect this information except as part of sort of like surveys and other kind of areas that we do on small subsets of the population. We really haven't done the big work of saying, okay, looking at, say, for example, Medicare claims. What is the quality of care for people with and without specific disabilities? It really hasn't been done, and that is an area of great need. There is the problem, and we're facing this even trying to do work here, that not everybody who has a disability needs accommodation, and not everybody who needs accommodation identifies as having a disability. When my father, who was very hard of hearing, used to go to appointments, I would say, "What happened at your appointment, Dad?" And he would say, "I have no idea," because he was very hard of hearing. But if he had been asked ahead of time whether or not he had a disability, he would have said no, even though he would have really benefited from accommodation. And so we're struggling with this. How do we collect information on disability? How do we collect information on accommodation? And that continues to be something that we need to work on best practices for. There's also a gap in knowledge about responsibilities, and I didn't put this up, but from our survey, we found that physicians, for the most part, had no idea whose responsibility it was to collect this information or accommodate patients. And of course, the answer is that it's everyone's responsibility. But in healthcare settings and trying to improve systems, we really need to define it more clearly. Unfortunately, all of these problems really add to the negative bias that we observed in our studies, which is that because there's really problems with knowledge about whose responsibility this is, how to collect the information, who to collect it from, who to accommodate, who has a disability, it sort of adds to a lot of the negative bias that we observed in our work. And so I guess the question now is really what can we do? And this is something that I get asked a lot. What can I do today? And I will say there are things that we can do today that all of us can do today. I'll say another thing, which is that I gave this talk last week at another place, and somebody said to me, "Why are you doing this work? It's so hard." And I will say, I'm very drawn to doing this work because it's hard, because it matters, because I think we have the opportunity to make a difference for the lives of our patients. But I acknowledge that, yeah, there are things that are hard. I will also say there are things that are very, very easy. And for those of us in clinical practice, we should be trying to do them every day. So we were lucky to be part of a PCORI Engagement Award that was run by PI Megan Morris at University of Colorado that brought together over 50 stakeholders to build capacity and identify research priorities for identification and acknowledgement, and then working to end disparities for people with disabilities. Megan and her team did a series of interviews, meetings, and working groups, and then I worked with that team to help put together a white paper. And we identified some important priorities. One is that disability needs to be recognized as a disparity population. Currently, NIH does not recognize this. CDC, HHS, CMS, ARC do identify disability as a disparity population, but it's not clear the priority that they've placed on this. I will say we've seen some recent movement from CMS, which we feel pretty good about. And I'm hoping that we're going to continue to see, and as well as HHS, obviously, because they fall under the HHS umbrella. And I think we are going to see some movement on this from NIH in upcoming years, which I'm really glad about. We need to remember in our own work that when we are doing diversity, equity, inclusion efforts locally and more broadly to include people with disability. I will continue to advocate for this, but I do think one of the pieces is data collection, which I'll get into in a minute. So improving data is really needed. So we are not currently nationally required to collect information on disability. It is included more in health and healthcare surveys as a result of some of the Affordable Care Act provisions. And I think that we need to continue to push locally and nationally for documentation of disability at the time of registration in healthcare settings, as well as documentation in electronic health records. I'm proud to say that Cindy Barnard and her team here have been very supportive of this work, and we're working to try with National EPIC actually to try to identify a way to have a field for disability in our electronic health record here, as well as a field for accommodation. Additionally, and Cindy's team has already done this here, they're collecting some information on communication disabilities in MyChart, and we hope to expand that in the future. One of the challenges is there's a lot of issues on the back end. How do you get information from MyChart to EPIC? How do you put the information in EPIC in a way that clinicians see it? Because I think this is really a challenge. We're overwhelmed in clinical settings with the amount of alerts and flags, and how do we do this in a way that doesn't further burden clinicians, but really can help our patients who need accommodation and need improved care now. We're continuing to try to conduct multi-stakeholder pragmatic research, and I will credit Carol on doing this even better than most. We are currently working with Access Living here. We're hoping to continue to expand our sort of stakeholder network. And I can thank Jen Brown at ART for helping us with this, because we've really had some support there, and we've been grateful for that. We really need more research on the extent of and determinants of disparities for people with disabilities, and we need to figure out implementation in real world settings. Intersectionality is huge, and I will say that rates of disability in non-white populations are much higher than in white populations, and I think the identities intersect and compound. And when I often think about this, I worry that many of the racial disparities we've seen in access to healthcare and in health could in part be related to some of the barriers to care for people with disabilities, because the rates of disability are higher in populations. And so I think we need to continue to think about how we're going to do this. And then the question is, what can I do now? And I will say bias and competency in healthcare teams is a thing that we can all do today. There are good resources online. The United Spinal Association is one. There are others. We are happy to share with participants in this webinar about where you can get information on etiquette. And I do think etiquette is a really great first step. We talked about person-first language, but really just asking people how they identify, how they want to be referred to, what kinds of accommodations they need, how they prefer to discuss their care. All of these pieces we can do now. They're not that hard to do. And I think as those of us who are clinicians should really think about how we can incorporate etiquette that's appropriate for people with disability, and really sharing decision-making about some of these questions with our patients with disability. We need to improve disability competency training, and we were going to talk about this, but we wanted to limit our time. We have done a series of focus groups with medical students nationally, as well as medical school faculty. There are people across the country who are developing disability curricula to improve medical education about how to care for people with disability, as well as how to incorporate more people with disability into both the healthcare workforce and into medical education, both as medical students and as teachers of medical students. And I think I'm going to call out DAC Med here, because the med students here have been incredible at really working and pushing for this. They run a conference. I have been inspired by some of the med students I've worked with here. And so I want to say thank you for your work. And we want to continue to work with you to try to incorporate disability education, both at Northwestern, but also nationally. And we have some results of that work with medical students and medical school faculty will be coming out in the next year. If we get that paper written, I promise you we're working on it. So I think that's really key, is how do we both diversify the healthcare workforce, and how do we train folks in medical school? I do think one of the pieces we're working on here that's still a challenge is getting buy-in from LCME on incorporating this as one of the competencies for medical students. And I know this is hard because the curriculum is already so packed, but I think this is super important, and it crosses all kinds of issues that are important to address. And I feel like we're going to continue to push for this. Again, one last shout out for etiquette. The United Spinal has some things. Why etiquette? If you are a person who enjoys having a physician speak to you respectfully, this should be pretty simple to understand. I think really learning about the etiquette, and as I said, United Spinal is one source of resources. There are others. It's just a few things, asking people, not touching a person's wheelchair, talking directly to a person who has hearing loss, who may read lips, just a few of the things. There's also this, the ADA National Network has additional information, as well as like a lot of online resources, including guidance for accommodations, especially around specific things like, for example, radiologic procedures. So I think that, as well as safe transfer techniques. So I think a lot of information is available now. And as I said, some of the stuff is easy to do. I'm going to leave you with the last thought of like, when in doubt, ask. I couldn't believe how many physicians, both in our focus groups and in our questions and survey questions, didn't realize that the best thing to do is ask the patient. But of course, the patient is always the expert. And I think that's what I sort of come back to again and again. We'd love to hear. I wanted to leave time for questions, and we're always looking for opportunities to collaborate. So I appreciate you tuning in, and I'd love to now hear from all of you.
Thank you, Carol. Thank you, Tara. It was a wonderful presentation, and I'll open up, there are some questions coming in. I'll open up the Q&A and get the conversation started. Our first question is from Cindy Barnard. First of all, thank you for the incisive, comprehensive presentation. And her question is, what do you think the potential is for a national standard for a concise disability assessment and documentation that lives in the electronic health record?
I'll just say really quickly, and I'll let Carol chime in after. We were just on a listening session with CMS that related to this, and they had kind of experts from a lot of different places, but every single person said we need to collect this data. So they've heard it, they know it's out there. I just think the question is, I think they're going to face a lot of pushback about it. I think there's potential. And again, I feel like it's our job to continue to highlight the disparities so that CMS and others will see the value of why we need the information. But I'll let Carol jump on.
Yeah, I think also we're seeing, this great support from National Epic is really giving us hope, and we think that it will push other EMR systems to adopt similar approaches to really support the documentation. I think the disability assessment piece of this question is really interesting and comes back to this issue of identification of disability and definitions of disability, and the measurement space there are vast needs in the measurement space around understanding and documenting disability and doing that in a concise way that can work in the clinic flow. So I do think there's some significant need there, but continues to be more and more interest in this space. And I think that we will see some movements here even within the next couple of years.
Yeah, there seems to be it's a catch-22 when you don't have a consistent definition of how we define the population. It's hard to identify the disparity or the magnitude of the disparity. And one way to do that is to study the disparity and identify who it impacts most, and then use that as a definition for the target population. So it's sort of where do you begin in the absence of either a sort of common definition and way of assessing disability status consistently, in a way to measure the impact of the disparity on that population. So challenging work either way from a measurement perspective.
And one thing that I'll just add in there is that in some places, fortunately not here, but in some places there is some resistance to documenting disability in the EMR, because then you have to have a standard of accountability around the accommodation procurement. And so this is something we're continuing to work through around those attitudes of the ADA, and helping clinicians come to see that providing better care for people with disabilities actually helps everyone. And we can do this in a way that supports kind of everyone at all systems of care.
Another.
Yeah. Go ahead.
Go ahead.
No, I was going to add, it is interesting. There is pushback about this because of the fact that if you know the person has a disability, then it becomes a problem. So this is why I think we need the national mandate. I just think the question is, how long will it take to get there?
Another question we have is, I think it relates partly to the your things we can all do now set of comments, but as you talked about from your paper, the type of exam room and the accommodations that might be sort of desirable, or something that would help to address some of the access problems that you described in the qualitative work you presented today. The question is really from a if you're in a community clinic, federally qualified health center setting, or someplace that has really limited resources for facility renovation and other sort of certainly hiring additional staff, et cetera. What are things that a low income clinic out in the community or providers in a small practice can do immediately to begin to try to provide better and safer care for the disabled population?
That's a huge challenge. So private practices have access to tax credits. So there are tax credits for purchasing accessible equipment that were part, I believe, of the Affordable Care Act. So it's actually different for federally qualified health centers and nonprofits than it is for private practices. So in a way, there is this incentive for private practices, but again, the answer is always, well, if you're a nonprofit, you can't use those tax credits. And so that is a challenge. And I think part of it can be training and education. Some of it is when the equipment is replaced, making sure that there's someone that's advocating for replacing with accessible equipment. I will also say it would be great to have a height adjustable table and a lift in every room, but you don't need it in every room. You need one, really, because it's unlikely you're going to have to use the same, have the same table at the same time on any given day. The problem with that becomes the scheduling. And so that was why advocating some of those procedural changes so that you could actually use a room for multiple providers, that is the accessible room, and that actually minimizes the cost. You only have to buy a table or a lift for one room. It's not perfect, and the difference in cost is a lot. I mean, it's the difference, as I priced it a few years ago. You can get a pretty basic exam table for $400. You can get a height adjustable table for about $4,000. So it's a real difference in price, and for low resource settings, I know it's a huge thing. I think the question is, it has to in part be about the priorities and how you do it, and in terms of both procedures as well as when you're re-upping the equipment. So I think that it's challenging. I agree. And training the staff is also challenging. And I think that staff turnover becomes an issue in settings where, that tend to be lower resource as well. So I understand this is a challenge, but important, because as we know, the intersectionality suggests that disability and SES are very tied. And so people who are getting care in those places are more likely to have a disability.
So, moving from the end of the spectrum of, practice today to the pipeline, as you discussed, physicians not feeling prepared, not knowing how to care for people with disabilities. You talked about a bit at the very end about changes or evolution of medical school curricula and education. Can you say more about maybe the involvement of AMC or AMA or others, ACGME, in the the development or incentives to more rapidly develop that content, and how does it also relate to increasing work to accommodate medical students with disabilities?
We just presented on this topic today, and I'll pass it up to Carol in a second, but I will say we've heard on the word on the street is that there's not a huge appetite for this from accrediting bodies currently. However, if there continues to be the needs expressed by students and trainees, I have a feeling that will change. I think it is a challenge to do anything different and have accrediting bodies and not acknowledge why it's important. But there is a push, and there are some schools that are doing this really well that could set the standard. And I think we're one of the ones that's really working on our curriculum here. So I'm proud of that. And shout out to Allison Kessler and Leslie Rydberg for doing some great work teaching our medical students. And I think there's a commitment to continuing that work here. So that's something that we're excited about and I think has potential. But in terms of movement from accreditation bodies, we haven't seen a lot. I think we're going to continue to push for that. And I think there are students who are pushing for that. And you're right, some of it does come from students who need accommodations. I will say there exists a lot of work by Lisa Meeks and others on technical standards at medical schools and how technical standards actually may discriminate against incoming students. And we actually have a Northwestern medical student who's starting a project on that. If anyone wants to participate, we were just saying we needed one more person, but it ends up being really interesting mixed messages for students, which is that, oh, we can accommodate you, but also you can't come to our medical school if you can't draw blood and do CPR. And that just feels really strange for students who are applying and need accommodation. So I do think we need to clarify the messaging. I think some of that would help with some of the accreditation issues. I think AMA has come out in support of having inclusive technical standards, for example, but it's not, it's not a constant message, a consistent message, and I think we struggle with that. And Carol, I know you have some things to add here.
Yeah, I think on top of that, we're seeing all these clinicians who are coming out and saying, I'm really ill prepared to work with this population. And one of the big problems that we see that we didn't get to talk a lot about today is that in medical schools, typically, they're cramming a lot of content in. And so the answer usually when you say we need to add disability to the curriculum is an easy answer, which is we don't have space for it. And it's hard to push back on that, except when it's not, because disability belongs everywhere. Disability is part of every facet of medical education, from how they're supporting trainees to also how you're addressing every part of clinical care. And so what's been really cool in some of these student movements and other kind of grassroots movements to really infuse disability into medical education is that people are figuring out like, oh, I can bring in a standardized patient who has a disability. It may not be a disability focused exam that we're learning, but why not think about how this very common occurrence occurs in everyday practice? And so there are kind of these little movements that are happening more and more, but again, we're still seeing kind of stagnancy and leadership in these areas. And I think that we're waiting for more of a critical mass of demand for the accreditation standards, because they're going to be really hard to enforce, at least up front, when we know so many med schools will fail.
Of course, that opens up an opportunity for people on this call to be part of the voices for encouraging that, I will say. I have 1 minute left, and I want to add a couple last words based on some of the questions I've seen. One is that for people who work in the NM side, there is an employee resource group, and we actually have spoken to that group, and they are vibrant and awesome. And if you are an NM employee, you should join that research group. And reaching out to Stephanie Salantine, I believe, Salatine is a good way to do that. I will also say there was a question about community organizations, and I mentioned Access Living. There are others, but maybe Carol, you want to say in the last 1 minute something about Access Living.
They're incredible national leaders advocating every day, doing this work across communities in Chicago. But again, people with disabilities are everywhere and in most communities. And so kind of creating space for them in all of the work and recognizing their involvement in community organizations, I think is important. And there's a lot, I've partnered, I have longstanding active partnerships in various research with community individuals at the community level who have been incredible thinkers and partners in this work. So I'm glad to see this question and hope that people will consider expanding their team.
Thank you all.
Thank you so much.
Thank you.
Have a great day, everybody.